everyone. Hello, students. Today we have a special guest lecturer. This is Dr. Tim Farrell. He is an associate, he's a professor, he's a medical doctor and a professor of medicine of geriatric, of medicine and geriatrics division, associate chief for the age-friendly care at the University of Utah School of Medicine. He's here today to answer a few of our questions, and I'm going to turn a little bit of time over to you, Dr. Farrell, to introduce yourself. Tell us just briefly a little bit about your background, maybe how you got into medicine and geriatrics, and anything I might not have included.
Hey, thank you, Dr. Perkins. Glad to be here. As you mentioned, I'm a faculty member at the Division of Geriatrics, and I wear a few other hats as well. I'm a physician investigator at the VA, at the Geriatric Research Education and Clinical Center, or GREC, and I also direct the University of Utah Health Interprofessional Education program. So I would imagine some of your students may have taken those IP courses over the years. I am a transplant, if you will, from Massachusetts. Did my residency and fellowship training in Rhode Island, and that's really where I kind of got interested in geriatrics. I started seeing older adults and sort of spending some more time with them than some of my younger patients. I was in a family medicine residency initially before doing an internal medicine-based geriatrics program, but really enjoyed the complexity. And someone came up to me, actually, an embedded geriatrics educator came up to I think my second year of residency and said, "Hey, have you thought about geriatrics as a career?" And that's the rest is sort of history. I've kind of really dived into it and enjoyed it.
That's awesome. Thank you. What's your overall practice philosophy of care in geriatrics, if you have one?
Yeah, I think it's really guided by the age-friendly context that you alluded to earlier. And for your students, there are the 4 M's of age-friendly health systems. So it's medications, mobility, mentation, and what matters most to patients. And so that what matters most piece is so critical that I've actually changed the way that I interview patients. If I meet a patient for the first time, obviously I'll address their chief complaint, but either up front or very shortly thereafter, I'll ask them what matters most to them, because that really drives everything else that we do.
That's excellent. I was going to ask you about what was meant by age-friendly care, but I think you described that well. In context of that, we just learned about motivational interviewing a few weeks ago. Do you use that in your practice, or how does that work into the what matters most part of the age-friendly care?
All the time. It goes hand in hand. And if I'm not actually actively engaging in motivational interviewing, I'm considering where a patient is on the Prochaska stage of change model. So it's critical, because you don't want to advance a discussion when a patient clearly is not ready. On the other hand, you don't want to miss an opportunity to change a treatment approach or what have you, if they are truly ready to do so.
So with that, do you have any examples of challenging situations and scenarios where you had to assist patients in making challenging decisions or overcoming barriers or transitions of care that you've experienced in your career, where you had to apply some of these concepts and tools?
All the time. It's actually hard to think of a specific example, but I think probably the most common one, you mentioned transitions, these goals of care conversations come into play. One example would be, it's not uncommon for a patient and family to be presented with a number of options for, let's say they're coming out of the hospital and someone says, okay, we're going to send you to a skilled nursing facility, right? And the patient and or family may have absolutely no intention to do that. And so they may very well need that level of care. So then it becomes sort of this almost a negotiation, if you will, about making sure their needs are met, but also honoring their preferences and goals. I'd add another place where this comes up frequently is advanced care planning. And that's something that a really important point for your students is that it's not just like, okay, let's fill out the advanced directive and the pulse form and we're done. It's really an ongoing iterative process that can change from year to year, month to month, day to day. So yes, this comes up all the time. And certainly I know with working with our care manager in clinic, our embedded care manager, goals of care are part of, I believe, a required discussion that care managers have in terms of meeting Medicare requirements. So this is absolutely everywhere, and it's only going to become more embedded in geriatric care.
You mentioned some interesting points. I just wanted to share briefly that I totally agree with you on those transitions of care being really challenging, because oftentimes they come with, unforeseen needs for transitions of care. And from my experiences, what I've noticed is understanding why a person, a client or a patient may not want to go to a skilled nursing facility is really important. Sometimes it's because they live alone and have a cat that they're worried about, so trying to make these interesting, creative workarounds for their pets or for other types of situations can really help reduce their barriers to going to a nursing home. So I appreciate that you mentioned those complexities of care. And then transitions, you talked about late life, end of life planning. I think that's super essential and important. My response to that too is that I've noticed that we have to do a lot of education as clinicians and care managers into trying to help break down maybe previous conceived notions of what hospice is or what end of life interventions might look like, so that we can almost re-educate our patients and our clients and their family caregivers to help them see a more holistic view of what end of life provides and why it's important to make it in a certain time frame even.
I think that's right. Just two observations. One is that the goals of care discussions are so incredibly important, because if you start going down a path with a patient but haven't really elucidated the goals of care, you could have the best plan of care in the world, but the patient's not going to do any of it because it doesn't align with their goals. So that's one thing I try to teach the learners with me. The other thing is when you're looking at, you mentioned sort of preparing patients and families for kind of the continuum of care and what to expect. A very common question I get is, a patient goes to a skilled nursing facility and where's the doctor? Where's the medical team? Because they're used to being rounded on several times a day, and then all of a sudden they go to a different location. So aside from where they're going in terms of their continuum of care, there's also, as you said, a really important need for education about what to expect as they sort of encounter these different transitions. And I'll give you just one more great example. So all my patients are my favorite patients, but I have a 106-year-old patient who I think probably is at the top of the list.
Did you say 106-year-old?
106.
Oh, wow. Okay.
She just passed away, but she was she was getting sick, and we were talking about hospice, and her family member said, "We don't know what to do. She's never been sick before." She's 106. So she made it to 106 because she was so healthy her whole life. And the family had absolutely no idea about hospice, what it was, or what to do if she got ill, or who they should call. And so admittedly, I don't think I had those, aside from, doing the advanced directive document, I don't think I'd had those conversations because she was doing so well. She was still driving at 106, probably more safely than patients half of her age. So I think this really points to the need to individualize these discussions. And that gets back to what matters most to the patient.
Yeah, you hit on something that it's been something I've thought a lot about, is this need to, I would like to maybe call it like a bookends transition, where a care manager or a case manager in the hospital, and then whoever received the patient and the family caregivers in the skilled nursing facility kind of work together in concert to discharge, but then also admit this patient. I like to say that this first few days, 72 hours, is really tenuous time. And it's not because the orders haven't been processed or, all of the little inner workings behind the scene haven't been done. It's just, like you mentioned, it's really important to think of it from the patient's perspective. I worked at the Huntsman. It's a beautiful hospital, really great culture of care. But, you go into a skilled nursing facility, the ratios are different of nurses to patients, CNAs to patients. And the doctor, if they admit it on the weekend, the doctor may not be in house at that point. So, they may not see a doctor for a couple of days. So just, helping them to understand from, the discharge time all the way till the, first couple of days that they're there to help them settle in, I think is huge. So
yeah, and even if you're one of the students listening, even if you're not going to be working in the skilled nursing facility, you very well may be, but it's really important to know what patients' families can expect when they get there, and that also helps everything from what orders you might write. As you said, if the house physician is not going to be there for a little while, you've got to kind of get this patient through and have a plan between now and that time when they are actually seen by the physician. So understanding that really helps, especially in the outpatient setting where patients may be going to assisted living, or they may be going to an independent senior apartment or subsidized housing. There's all kinds of different locations of care, and patients are really looking to their primary care team to help them navigate that.
yeah, and when you say that, this kind of hits on my next question about interdisciplinary team care. My brief perspective on it, my history is that it's hard because you have, for example, the case manager in the hospital discharging, and they understand the inner workings of home health and skilled nursing and long-term acute care and those levels of care. But how do you, I guess, as a geriatrician in your clinic, how do you collaborate in an interdisciplinary format? Do you work with care managers, and what is, the last question is, what makes it an excellent care manager or excellent interdisciplinary team in your opinion?
Yeah, if we had a whole other hour, we could really dive into this one because this is such an important question but I'll try to take an initial shot at it. So the interprofessional approach to care is absolutely critical, but it's also, it doesn't have to be, but it can be more time consuming and somewhat difficult to get all the people that you need to talk to sort of aligned, especially when, even within the same health system, you mentioned Huntsman, right? If you got a patient at Huntsman and I'm down the street at the Madsen Geriatrics Clinic, there's going to be faxes and phone calls and Microsoft Teams and all these different things, different platforms. And so there's sort of this logistical coordination barrier that comes up. There's probably no replacement for sort of the warm handoff, the telephone call to somebody. Of course, that's not always possible, so we find ourselves working somewhat asynchronously. But to your second question about the importance of an outstanding care manager, which we really are fortunate to have at Madsen, that person can do a lot of this coordination of care. So if I'm in seeing a patient behind the scenes, they may be contacting the case manager at the hospital. They may be contacting Medicaid or aging services or state agencies, all kinds of things that are quite time consuming but absolutely essential. And otherwise these things kind of fall through the cracks. So interprofessional team-based care is where things are going. I would also add just a lot more fun, right? It's more fun to practice with other people, and I always learn something from the care manager. They're up on the latest Medicare guidelines and state guidelines, and they know the facilities. They also kind of keep a running list of our patients who are hospitalized and sort of know where they are at any one time. So usually my first call when I find out someone's been hospitalized or going to ER is to the care manager, because I know that they're going to be able to kind of follow through and then kind of get everything teed up that they'll need for their next transition.
That's a really good point. I think that's what I really hope for my students in this course to get from this is, even if they don't become a care manager, how will they, interface with care managers for patient benefits, and what can they learn and from case managers and the resources that they have to share with them. And like you said, we all kind of have to work in silos a little bit in our specialties, but that collaboration is where we really can learn from each other and, learn in a more contemporary format, I think is what you're saying.
Yeah, I guess, they say everything you need to know is from kindergarten. And if you think about the sandbox in kindergarten, there's a lot of parallel play going on, right? So this is a matter of getting people away from doing siloed care or parallel play and getting people more integrated. And it's not always easy, and it can be more time consuming. But once you get a team that's really kind of well oiled and functioning effectively, it actually saves time, because if you've had the longer discussion about what matters most, it might take longer initially, but then every subsequent encounter, you don't have to focus on every single little thing that's not relevant to what matters most to that patient. So it actually becomes more efficient over time.
Yes, it sounds like a good way to prioritize what we can do within the time frame that we have that will actually have better patient outcomes based on their priorities as well.
I mean, it's such an amazing filter, right? It's not what matters most to the payer. It's not what matters most to the neighbor, unless it matters to the patient. So I think that's, now another layer of complexity is we can't always find out what matters most to the patient if they have cognitive impairment. And so then it's always, and this is a really important point for your students, even if a patient is cognitively impaired, it's really important to do your best to find out either in the moment and or in the past what their wishes were or are. And then of course, integrating that with their caregivers and those around them. But just because they have maybe mild cognitive impairment or mild dementia, or even if they're more severely impaired cognitively, it doesn't mean that we're not obligated to ask. We still need to try to find out what matters most to them.
Do you deal with that a lot in your clinic?
Yeah. Oh yeah, it comes up all the time, and you see patients progress through various stages of impairment, or maybe they have an acute medical insult and they have delirium, and so they have fluctuating cognition. So it can be challenging at times to assess that, but that's also where having that longitudinal relationship with the patient really helps, because then you have an understanding of what their wishes most likely are.
I think you're bringing up a good point. We've been discussing ethical principles, and one of them that I would like you to kind of touch on just briefly here is autonomy with cognitively impaired older adults. What does that mean, and how do you, safeguard autonomy in a cognitively impaired older adult?
Yeah, well, that's such a good question, because there's, as I'm sure you probably discussed, there's competing ethical principles. You have autonomy, you also have beneficence. And so that's kind of where a more paternalistic approach comes in. You have kind of justice, equity issues, and non-maleficence or doing no harm. But really what this comes down to often is autonomy versus beneficence. There are times when you have a patient, a so-called unrepresented or unbefriended patient, where no one knows their wishes, they don't have a surrogate decision maker, it's not documented anywhere. And sometimes you have to resort to the best interest standard of what you think is best. But even then, it's still important to try, when the dust settles, to kind of track down what their wishes are. That's probably the most difficult case, where you have absolutely no idea who the patient is and what their wishes are, and they're just incapacitated, can't talk to you for whatever reason. But most of the time, there are key informants. What's actually interesting in Utah, not to get too detailed here, but if you can't reach anybody, if you go through the hierarchy of decision making and you've gone through, children and spouses and relatives, someone who's shown special care and concern for the patient, who may not be a relative, actually may have some standing in terms of decision making for these folks. So it's extremely complex, but almost always you can at least get a sense of what might matter most to these folks.
And then in another complex terms are the two that we've been discussing in the past weeks, is the concept of decision capacity to make decisions versus competence. Would you care to comment on the differences between those a little bit and help our students understand, I guess, the two terms more concretely?
Yeah, I'm happy to do that. So it can be quite confusing, because these terms sort of refer to just about the same thing, but just in different contexts. So the term competence is typically more of a legal term, so that a judge, might have a hearing about someone's competence. Capacity is more of a medical term. So that's the first distinction. The second key point is that there's different types of capacity. And so not so long ago, in the legal system, it wasn't that uncommon for one of these unrepresented patients to go up for a guardianship hearing and the judge to say, basically they're not competent to do anything. And so it removes their constitutional rights. So you're talking about autonomy. So not just their right to make decisions about medical care, but their right to vote, their right to choose with whom they wish to associate. That all kind of went down the window. Fortunately, there's this sort of new paradigm of what's called supported decision making. So if you have an older adult who you're worried about their lack of capacity to make medical decisions, the question should not be sort of a categorical yes, no, they or do they not have this capacity. There may be some cases where they absolutely don't, but that should be rare. Most of the time it's, do they have capacity to make this specific decision about let's say it's about their medical care, or maybe it's about their finances. That comes up a lot. And then the question is, okay, if they do not have that capacity, and that there's been a formal assessment, which is really important to do, can they be supported in that decision? So if they had their son or daughter available, for example, could that person help them think through the decision, or at least express some sort of basic preference? And probably I could talk a little bit more about this, but one other thing that's really important is the capacity to decide or to choose who is going to sort of be your surrogate, who's going to speak on your behalf. You've got to be substantially impaired before someone says you cannot make that decision. So virtually everybody should be able to say, I want this person or that person to make a decision for me. And that's really quite fundamental. So it's a very interesting topic. One additional quick point is that it's a misconception that you need a psychiatrist to do a capacity evaluation. That may be necessary for really complicated psychiatric illness that's kind of overlying this, but a primary care physician, a geriatrician, that should be in their toolkit. They should be able to do a capacity assessment.
I'm glad you said that, and you talked a little bit about that, because some of our students will go into being nurse practitioners and such, and I don't know that we always talk about this as much as we need to early on, so that they can become prepared to be doing these types of cognitive assessments. Even if you're a family care practitioner, you're going to see a lot of older adults, right? So a quick screening can't hurt, and an early intervention.
That's right. And so one of the hard parts here is that there's not a lot of tools out there to conduct capacity assessments, but I would refer your students to Paul Applebaum, who has sort of 4 different criteria for capacity assessments. And then there's also tools to do this. One is called the ACE, or Aid to Capacity Assessment tool. The other one is called MedSail. And MedSail is kind of nice because it goes through actual scenarios. So for example, you can ask a patient, someone showed up at knocked on your door and offered you a chance to win a sweepstakes, what would you do? And this has to do with patients who might be vulnerable to financial abuse. There's another question I think about, there's a fire in your kitchen, who would you call next? What would you do? And you kind of go through this process. So it's a little more anchored in specific contexts.
What was the first one you mentioned? I missed that.
It was one about, I can't remember the exact scenario, but I think if someone says, we will give you, you'll win a sweepstakes, or you'll win $1,000 if you'll just give us your Social Security number, or something like that, just because of the prevalence of financial abuse in our community and across the country.
So I just wanted to switch tracks, because I know that you've been done a lot of work and research with social determinants of health factors in older adults. Could you tell us a little bit about your philosophy and the initiatives you've taken toward improving these factors for vulnerable populations and older adults in our community?
Yeah, so one thing that is a bit humbling as a healthcare provider is that healthcare is really just the tip of the iceberg in terms of what are the factors contributing to overall health, and the social determinants, namely food, transportation, housing, all those things, you don't have those sort of essential components, then really you're not really addressing the underlying issue. So it's a challenge, right? Because we're often trained, understandably, to focus on the medical concerns, but very often, sometimes the reason why there's a medical concern is related to something that didn't happen. So, for example, a patient who has, let's say, an older adult who does not have easy access to transportation. And then we kind of wonder why they have uncontrolled blood pressure, and then because they can't get to the clinic, and then they might have their first stroke at an earlier age. And we do know as well that, in terms of the focus, especially over the last few years on health equity, that populations that do not have these essential services and systems kind of in place, they might, for example, be more likely to develop the chronic disease at a younger age. So maybe they had untreated hypertension because of lack of access to resources and transportation. Then they have their first stroke at an earlier age, then they have a longer period of disability. So it's not just a theoretical construct. This is really something that we see all the time, unfortunately.
How do you deal with that in your clinic? Are there anything specific that you've been working toward to help mitigate social determinants of health and improve outcomes?
Yeah. So I guess more broadly speaking, there's also kind of this overlying ageism that we're confronting. Mm-hmm. And so where older adults might be assumed not to be worthy of receiving resources. And so one of the things that I worked on early in the pandemic, going back to the crisis standards of care. So there were these standards that in terms of who would get resources in a, sort of in a rationing situation, which frankly, we actually are now, right? We are rationing care because we're not doing elective procedures as often with the hospital being full. But there were provisions in the Utah crisis standard, and not just Utah, other states too, that were frankly discriminatory towards older adults, basically saying if you are over such and such an age, we're not going to give you any resources, right? So we pushed back on that. We got them to remove that, and now it's based, on short-term prognosis and sort of an assessment of comorbidity. So the underlying thing is that just age on itself can't be used to exclude someone from a resource. So that's just one example, but with other social determinants, I think that gets back to our interprofessional team. Like our care manager, again, has been instrumental in making patients aware of services that they might not be aware of, such as, shared transportation services or ride services, things like that.
I find that transportation is a big factor, don't you? Especially for rural folks, because it's the difference of them being able to come to their clinic appointments or not.
Oh yeah, and also we're kind of in a virtual world now, and so a lot of our appointments are conducted that way. But and I think there's two ways to look at this, right? We should not assume that older adults cannot use Zoom. Many of them are quite facile with it and do it better than I can. On the other hand, last week in our clinic, I had a patient where our staff spent almost half an hour trying to get a patient to log on to Zoom, and we had to convert to a telephone call, which didn't work quite as well. And so there's sort of a technology aspect, and this trickles down from an age-friendly perspective to everything related to, let's say, the process for notifying patients about specialty referrals. So if they just call one time and hang up and say, well, gosh, we missed you and you've got to reschedule. What about the patient, older adult, who it takes them a few minutes to get up out of a chair and get to a phone? What if they had called back a few times? Maybe on the third or fourth try, they would have actually picked up an answer. So we can't blame the patient for that. It's really that our systems are not always set up in a way for something as basic as setting up an appointment for our older adults to really navigate well.
Yeah, exactly. I appreciate what you've said, especially about the pandemic and rationing care. I think it's such a huge thing. And earlier, it reminded me of earlier when you talked about dealing with older adults as kind of a case by case scenario. They're all very different, just like middle aged adults are all very different. So, and you gave a great example of the 106-year-old patient you had who was very active. And I think it's important to note that there are, people who are older adults who definitely are, faring better physically than others. But I do think that we have to keep that in mind as we decide, what is important for patient outcomes.
Absolutely. Individualized assessment is absolutely critical. I think that's true in rationing. It's true in point of care discussions. It's absolutely the case. If you look at not just the president, but our Senate, the average age of our leadership in our country, most of them are either older adults now or soon will be. And so that's a good thing, I think. But just to say that it'd be kind of ageist to say, gosh, we don't want to take advantage of the life experience that folks have to bring to the table when they've reached their older adult years.
Yeah, I think that's really important to change culturally. And on the same line of ageism, I've been wondering a lot lately about how do we get students in, different healthcare to get interested in becoming geriatricians or working with older adults. What ideas do you have any ideas for how we can maybe, we have an essential need for these types of people to go into geriatric care, but I'm wondering what ideas do you have for recruiting them or getting interest early in their education?
Yeah, I think, and this has been the subject of a lot of, I'll say debate or discussion in the geriatrics world, because you see all these statistics come out about, we have a shortage of geriatricians, and the same is true for primary care more generally. But I think really it's a matter of exposure. Once a student comes into the clinic, they usually say, gosh, I didn't realize, number one, how fun this is, and also how interesting this is, because some people don't like the complexity, right? Because these patients are more complex than most in general, on average. And for some folks, that's not appealing. That's understandable. But it really becomes kind of intellectually quite satisfying if you look at it as a challenge and not as sort of a negative in terms of complexity. So I think exposure. I think the other aspect of that is early exposure. So I didn't really get exposure until I was a second year resident, really directly. One of the nice things about my residency is in family medicine, you had to have a panel of patients in the long-term care setting. So I had a few patients I got in my second year in a kind of a board and care facility setting in a nursing home. But not all disciplines have that type of exposure. Also, I think you can look upstream in the educational pipeline. So we have at the U, some exposure for undergraduates, honor students, and so forth in geriatrics topics, I believe. But there's no reason we can't even go further up the pipeline. But I think things that have been shown to be effective are mentoring programs where you have a first year medical student, or even in college or high school with exposure. A really innovative one, there's actually been programs with students getting a break on their room and board to live in a setting where older adults reside, or having older adults conversely live where the students are. So there's all kinds of interesting ideas that way, but I think exposure early in the pipeline is helpful.
Yeah, I do too. I agree with that 100%. That at least for my own personal experiences, that's what got me interested in working with older adults. I was working at a skilled nursing facility and just, really learning how to love these people and gain so much from their perspectives and their life histories and just their generation. And it's just been, it's really rewarding if you can get that experience. I think early in a career would be nicer, but at any point would be great, I think, to get more of our clinicians and healthcare team interested in. And even if you don't work with them one-to-one, you're always going to, unless you're like maybe in pediatrics, you're going to, if you're in a healthcare setting, you're going to be managing care and working with older adults. So it's great to get any kind of education possible. So that being said, I was going to ask you finally a couple more questions. Key practices that you would like all geriatric health professionals to adopt. Are there any like specific, if you could like impart anything that you would like to be a takeaway for people working with the older adult population?
Yeah, I know this, we already mentioned this, but I think it really comes back to the 4Ms because they're so powerful because they cut across, they're not discipline specific, they cut across all disciplines. And so I'll tell, usually it's the medical residents I work with, but anyone who I'm working with, if you do nothing else during an encounter with a patient, at least try to make sure you've thought about those 4Ms. Even if it's a phone call with a patient or an office visit or some sort, any type of encounter, because there's often, again, to that iceberg analogy, there's often something lurking underneath the surface of the water that is driving the discussion. I think also along those lines, it's not being afraid to take a little extra time. I mean, I think that's probably one of the most valuable things that we have and to give. And even if we don't, if we're not able to come up with a treatment for something, at least we can give people our time and kind of our attention and really be present with the patient. So in order to have a what matters discussion, that's not the time to be, typing on the computer or checking your pager. I mean, really, that's the time to be kind of that patient at that moment is the most important thing that you have going on.
I bet they really appreciate that too.
I think so. I mean, I think it's got to be genuine, right? It can't be forced, like a checklist. Hey, what matters most to you? Okay, now what's no, you gotta be prepared to spend 10 or 15 minutes kind of discussing that.
Do you feel like spending more time on the front end does save some time?
Oh, no question, and especially well, the other thing that becomes important is how do you capture that discussion so that the next provider in a different setting appreciates that. And I don't think we currently have a great way to do that, but it often comes down to someone being diligent and looking back to the last few notes. So in those acute care settings, I always appreciate, I think people in our system do a good job with this overall. People look back and try to get a little more of a big picture view of what's happening with the patient. That's
a whole skill all in of itself, note taking and informatics, and we could spend a long time talking about that. But just to be like mindful of the time for you, I just wanted to know, and this is kind of more maybe on a personal note, I think it would be interesting to hear from you. What drives you in this area? Like why are you interested in geriatrics? What do you love about older adult populations, or why did you get into this, I guess, is the final question. Yeah.
I think it's just so interesting. Like, I mean, I think there's sort of, speaking of, sort of stereotypes, I think there's, I probably had this at one point too, a stereotype that, gosh, caring for these patients must be boring or dull or not, important or worthwhile. But you quickly realize this is really where the action is in healthcare, right? So if we can fix, reimbursement and value and quality and all those things and sort of the quadruple aim or now quintuple aim for older adults, we really can fix it for everybody, because this is where this is where the healthcare cost issues are. This is where the complexity is. And so it's really actually a very exciting time to be involved, not just at the patient care level, but also at the policy level with all the ethical issues you brought up. Older adults were kind of front and center in terms of how we think about the pandemic. So even, notwithstanding the really kind of the joy in practice, because geriatricians are the most satisfied healthcare professionals. That's another thing. Aside from joy in practice, there's so much interesting and I think important work to be done in these other spheres that, there are entire careers that can focus on these issues that are out there for your students.
Well, I appreciate that. And I agree with you 100% that that's a nice statement that you made about fixing it for this population and fixing reimbursement and policies and care will really drive a new model, maybe, of care in the United States, which would be really nice to see. I'm hoping that in that we can fix like the social and, health promotion models and maybe bolster and reimburse them a little bit better. And, I think it'll actually help the medical model that we are more driven toward.
Yeah, we need your students to be helping us with all of these objectives. So, and I'm happy to meet with anyone who's interested in a career in this area.
That would be awesome. Thank you so much. I don't have any other questions. Do you have anything lastly that you'd like to add, or?
Oh, just to say, when you mentioned pediatrics, even there, you're going to get questions from grandparents about the grandkids. So they're not off the hook. And in fact, the other thing too is that it's becoming increasingly recognized, that what happens in early and midlife affects what happens to older adults. So I think there's going to be increasing opportunities to collaborate for geriatricians and pediatricians to collaborate. And
that's an excellent point. I love the idea of this crossover. And you reminded me of that when we talked about college students, maybe living in situations with older adults. I know there's been some studies about, older adults contributing to the care of, children, younger adults and such, and how it benefits those generations so much. So I think that's really important to note, that even in pediatric care, you still have to be knowledgeable and understanding of how to, discuss care with caregivers who are older adults. Oftentimes they are these days. So I think that's very important.
And caregiving is such an important topic. It's becoming a area of focus and excellence here at the University of Utah. So that's another place where I think students can find projects and activities and potential career opportunities as well.
Yeah. Thank you so much, Dr. Farrell. I really appreciate your time today. And I know my students will get a lot from this conversation, and hopefully a lot of food for thought for them as they move forward through this class and their careers.
You're welcome, Dr. Perkins. It was my absolute pleasure. Thank you for having me.
Thank you.